In this lecture, we will talk about gas exchange in the respiratory system. We will describe the exchange of oxygen and carbon dioxide between the blood and the alveoli and the blood and the tissues. We will include partial pressure gradients and their significance. At the very end, we will have discussed both ventilation and gas exchange. We will put this together to talk about ventilation and perfusion ratios and explain how this affects gas exchange. So gas exchange is the movement of gases, oxygen and carbon dioxide, between the body cells. In this example, we're talking about the lungs between the alveoli and the pulmonary capillaries, or the tissues between the systemic capillaries and the body tissues. We need to remember the structure of the respiratory membrane when we're talking about gas exchange in the lungs. Remember that gas exchange in the lungs occurs at the respiratory membrane between the alveoli and the pulmonary capillaries. Air moves into the alveoli during ventilation and then diffuses between the alveoli and the blood during the process of respiration. So the processes required here are ventilation, respiration, and also the perfusion of blood to the lungs. So respiration is oxygen and carbon dioxide gas exchange. We're going to talk about pressure gradients and throw a lot of numbers at you. So I want you to back up for a second. And before you delve into the numbers, think about the big picture. How should these gases move based on what we know of the use and removal of oxygen and carbon dioxide? So the exchange of oxygen and carbon dioxide should move in this pattern. We want to bring oxygen into the lungs. The oxygen in the alveoli then should be picked up by the pulmonary capillaries. And then that oxygenated blood will be delivered to the tissues. So the oxygen should then move into the tissues. The tissues will then use that oxygen and produce carbon dioxide waste through the process of cellular respiration. That carbon dioxide waste then needs to be removed from the tissues and returned to circulation. CO2 will then return to the pulmonary capillaries to be removed through the alveoli. And then as air is exhaled, that CO2 will be removed from the lungs. So no matter what numbers we throw at you, make sure that this general pattern is how it works out. We need to understand partial pressure gradients to talk about the diffusion of gases. Partial pressures are essentially a concentration or an amount of gas within a mixture. Gases will move with partial pressure gradients, just like other molecules move with concentration gradients. Gases will move from high partial pressure to low partial pressures. So we're going to use partial pressures to look at the diffusion of gases. Partial pressure is the pressure of any one gas within a mixture, and it's a measurement of the content of that particular gas within a mixture. The amount of gas in a mixture depends on the humidity of the air, the altitude, and the temperature. So how do we calculate the partial pressure of oxygen in inspired air at sea level? Well, essentially, we're going to take the amount of oxygen, 21%, and multiply it by the pressure. But first, we actually have to remove the amount of water vapor from the air mixture. So we take the total pressure of the air at sea level, remove the water vapor, which is 47 millimeters of mercury, and then multiply it by the percent of that gas. By the way, this isn't just for oxygen. We could use the percentages for carbon dioxide, for nitrogen, any of the other gases in the mixture. Here we're just showing for oxygen. Oxygen is 21% of that total gas. And if we get 21% of that number, we're going to end up with 150 millimeters of mercury in inspired air. Remember, this could change with altitude because air pressure decreases as we move up into higher altitudes. So is the air pressure in the alveoli 150 exactly? No, not exactly, because the air from the inspired air is going to mix with the old air in the lungs. So let's look now at the partial pressure of oxygen that's actually in the alveoli. It's actually a little bit closer to 100 millimeters of mercury, although it varies across the different regions of the lung. This is a general rule of thumb. So the amount of oxygen in the alveoli is about 100 millimeters of mercury. This is because we start with about 150 millimeters of mercury in the inspired air, and then that new inspired air mixes with the carbon dioxide and the alveolar dead space air and brings that number down. As we get that number down, it reaches about 100 millimeters of mercury of oxygen in the alveoli. There's a gas equation here to calculate that specific number, where we take the inspired oxygen in the air, which was 150, we subtract the carbon dioxide divided by 0.8. And that gives us 100 millimeters of mercury. Don't worry, I'm not going to ask you guys to calculate it. I just want you to see where these numbers are coming from. Let's look at some other partial pressures. So you may want to write these numbers down and track them as we talk about the diffusion of gases. The atmospheric air is about 150 millimeters of mercury of oxygen. The alveoli are 100. The pulmonary capillaries are deoxygenated, so that blood has just returned from the systemic capillaries, and that's at 40 millimeters of mercury. The PO2 will then equilibrate back to 100 as it mixes and exchanges with the alveoli. So the PO2 of the systemic arteries, once they leave the alveoli, is 100 millimeters of mercury. We get back down to the tissues and the oxygen is used, and we go back down to 40. So in general, for oxygen, we can remember approximately 100 when it's oxygenated and 40 when it's deoxygenated. These numbers will vary, and of course you'll get more specific values as you learn to get your labs measuring arterial blood gases and venous blood gases, but we can start with this general ballpark. So let's now talk about the exchange between the lungs and the blood and the tissues. We want to look at the partial pressures of oxygen and explain the direction of oxygen movement at these two sites. So we're talking about the exchange between the alveoli and the pulmonary circulation and the tissues and the systemic circulation. Let's start with oxygen exchange in the lungs. Air is ventilated from the atmosphere to the alveoli. It mixes with old air, and the alveoli partial pressure of oxygen is 100 millimeters of mercury. That oxygen level in the alveoli is higher than the oxygen level of the deoxygenated blood entering the lungs from the pulmonary arteries. That level of oxygen is 40. So we can see now that from the alveoli to the blood, we now have higher pressure within the alveoli air sacs and lower pressure within the pulmonary capillaries, and this creates a diffusion gradient so that oxygen will now move from the alveoli across the respiratory membrane into the pulmonary capillaries from this high to low pressure gradient. This is our first site of gas exchange. As the blood leaves the lungs, it is now equilibrated with the alveoli at 100 millimeters of mercury. That blood travels through the systemic capillaries and reaches the tissues. The tissue cells have a low oxygen level. Why? They have a low oxygen level because they're using it during the process of cellular respiration. So the tissue cells are going to be at 40 millimeters of mercury. And again, we have a gradient. We now have high oxygen in the systemic arterioles to the systemic capillaries, and low oxygen within the tissues, and now the movement of oxygen is going to go from the systemic capillaries to the tissues. So now we have this gradient from systemic capillaries to tissue cells, and we're going to bring oxygen from those capillaries into the tissues. This is the oxygen delivery happening to the tissue cells. Now let's look at carbon dioxide partial pressure gradients. We're going to look between the lungs and the blood and the tissues and the blood. But for CO2, our numbers are quite different. We have a smaller percentage of carbon dioxide in the air. But just like inspired air for oxygen, inspired air for CO2 mixes with old air that is fairly high within the lungs. So our CO2 levels within the alveoli are 40. Our tissue levels of CO2 are 46. Why are the tissues higher than the alveoli? The tissues are higher than the alveoli because this CO2 is being produced through the process of cellular respiration. So cellular respiration brings the tissue carbon dioxide level to about 46 millimeters of mercury. That travels through the systemic veins at about 46 millimeters of mercury and reaches the alveoli. The alveoli then mix with the inspired air. The pressure in the alveoli is 40 millimeters of mercury. The pressure of CO2 in the atmosphere is quite low, only 0.23 millimeters of mercury. So the numbers you need to remember for CO2 are 46 at the tissues and 40 in the alveoli. Again, these are ballpark numbers. You'll get more specific numbers when you learn about your arterial and venous blood gas measurements. Now let's look at the exchange of the tissues in the same way that we looked at oxygen. So the tissues are going to be our starting point for CO2. Why do we want to start here? Because it makes sense to me to start where it's being produced. So the tissue cells are producing carbon dioxide at 46 millimeters of mercury. That is high. The systemic capillaries have a lower amount of carbon dioxide at about 40 millimeters of mercury. So we have a pressure gradient for the carbon dioxide to move from the tissues into the systemic capillaries. That's our high to low pressure gradient. The CO2 is going to leave the tissues, diffuse into the systemic capillaries where it can be carried to the lungs. So carbon dioxide leaves the tissues and enters the blood capillaries, but with the 46 to 40 millimeters of mercury pressure gradient. Once in the lungs, that 46 millimeter mercury CO2 is now in the pulmonary capillaries. That's going to be mixing with the air in the alveoli. The alveoli have a CO2 pressure of 40. So again, now we have a high to low gradient moving from the pulmonary arteries, the pulmonary capillaries, into the alveoli. This is how the CO2 leaves the blood and enters the air sacs. CO2 now leaves the blood, goes into the alveoli where it can be expired and released out into the atmosphere. Take a second to pause here and draw yourself a summary diagram of the movement of oxygen between the lungs and the blood and the tissues, and the movement of carbon dioxide between the tissues and the blood and the lungs. Make sure that you can summarize all of these partial pressure gradients and where the gases are moving based on those gradients. Now that we understand both the ventilation and the gas exchange in the lungs, we need to think about one of the most important effectors of gas exchange. This is the ventilation-perfusion ratio. So gas exchange depends very much on the match between ventilation or airflow and perfusion in the lungs. airflow and blood flow should match approximately to allow this exchange of gases to occur. This we call the VQ ratio, or the ventilation-perfusion ratio, where V stands for ventilation, that's the air that reaches the alveoli, and Q stands for perfusion, that's the blood flow per unit area in the pulmonary capillaries. A normal ventilation-perfusion ratio is about 0.8, pretty close to 1, but perfusion is just a little bit higher. Looking at the lungs, we actually have different zones of ventilation and perfusion that change as we move from the apex to the base of the lungs. This is because perfusion and ventilation are changed as we move from those different regions. So perfusion is affected by pulmonary artery blood pressure, pulmonary vein blood pressure, alveolar pressure, and gravity. Ventilation is affected by pleural pressure gradients, as well as compliance, alveolar size, and surface tension. The ventilation and perfusion, when we look from the apex to the base of the lungs, the ventilation and perfusion are actually highest at the base of the lungs. That's because we have both a higher compliance and a higher level of blood pressure in the base of the lungs. The apex of the lungs has lower perfusion to its alveoli, and it has a swayed ventilation-perfusion ratio because of that. The middle zone of the lungs is approximately equal. Ventilation and perfusion are about the same. When we average out the difference between the apex, the middle portion, and the base of the lungs, we get a ventilation-perfusion ratio of about 0.8. This changes with body position. This is because blood flow and airflow change with body position. Body position in particular changes the distribution of pulmonary blood flow. When we're standing upright, the pulmonary blood flow to the base of the lungs is the highest. These are the dependent areas where the fluid goes more towards the gravitational pull. Lying down, pulmonary blood flow will shift to the dependent areas and distribute differently across the lungs. These are important considerations when we have a patient with a VQ mismatch, because a mismatch in the ventilation-perfusion ratio can impair gas exchange, and changing body position can exacerbate this mismatch. If there's a VQ mismatch, gas exchange is decreased. This can be both because of blockage of blood flow or because of blockage of the airways. For example, a blockage of blood flow, let's think, for example, a pulmonary embolism, blocks blood flow to a particular part of the lungs. That will lead to low blood flow with respect to a normal ventilation. That will lead to a very high VQ, meaning you have a lot of ventilation and very low perfusion. In this case, there will be no gas exchange because there's no or very little blood to that area that's able to pick up and release the gases. In the case of the blockage of an airway, we have low or no ventilation, but normal blood flow. That will lead to a very low ventilation-perfusion ratio because you have very low ventilation, but regular blood flow. In both cases, we have what we consider to be dead space. That is, areas of the lung that are not performing gas exchange, or where gas exchange is very low. It's important to understand that blood will be diverted away from non-ventilated areas to areas of better ventilation, and we call this a shunting of blood flow. Shunting of blood flow will remove blood flow even further from areas that are less ventilated. An example of shunting would be the dead space of alveoli created through emphysema. In the process of emphysema, alveoli are enlarged and damaged. This dead airspace will not be well ventilated, and the blood flow will be diverted to other areas of the lung. So overall, a VQ mismatch impairs gas exchange. And when we have a decrease in gas exchange, patients will have difficulty breathing and difficulty regulating their arterial and venous blood gases. All right, that's it for this one. Let me know if you have any questions.